Assalamu alaikum all. Thank you for the kind introduction. So I'll be talking about new treatment options for HIV and switching regimens. I think at this time we all know that switching regimens is important because of the potential toxicity and, as our colleague mentioned, due to aging. And also cost-wise, in UAE, the cost is almost the half of the price of the 3-drug versus 2-drug regimen. So I think these are the points I will be elaborating in my talk. So in recent decades, for the introduction, in recent decades, the human immunodeficiency virus infection has become a chronic and manageable disease like diabetes, hypertension, and all. The development of potent antiretrovirals has significantly reduced the morbidity and mortality, especially with the invention of integrase inhibitor. The effectiveness of these medications depends on daily oral intake. And treatment is centered on the highly active antiretroviral therapy, which consists of 2 or 3 ART taken daily, typically in pill forms. So now you can see that we have here people living with HIV, almost 38 million. This is data of 2021, and it's 95% are taking, so there's a pointer here. Yeah. So you can see 95% are virally suppressed, 95% are accessing treatment, and 95% who have, they know their status. So due to availability, tolerance of the pills, integrase inhibitors, and efficacy, and the simplified regimen, it's been accepted all over the world. The number of persons on long-term virological suppression has increased as compared to the other ones. The number of persons experiencing treatment failure, progression to AIDS, and the death has decreased. I don't remember last 5-7 years that I have seen any of the people who are not been diagnosed and coming with cryptococcal meningitis or pneumocystis pneumonia, maybe very less, maybe a couple of cases, 2-3 cases. There remains a subset of heavily experienced population in HIV that have multiple mutations. This is probably most likely due to non-compliance of the patients rather than the mutations that occur. In some patients, it can occur on its own. And there is a novel mechanism of action with lack of cross-resistance to other antiretrovirals, and there is innovative approaches and convenient support patients' adherence. So this would be very important to see. Again, non-adherence can lead to emergence of resistance that we all know. We always, on each presentation, when we talk to the patient, we just tell them that they have to comply with the antiretrovirals. So these are the first initial regimens for most adults and adolescents treatment. There's DHHS guidelines, IAS, AX, and WHO guidelines. So DHHS, bictegravir, FTC, TAF, then dolutegravir, 3-TC, abacavir, and then dolutegravir, FTC, or 3-TC plus TAF, or dolutegravir, 3-TC. In IS, almost the same, and in EX, there is a few changes here and there, and WHO probably prefers dolutegravir 3-TC plus minus TDF if the hepatitis B is negative. So when the integrase inhibitor came a few years ago, we thought that we have achieved a very good potential treatment with less interactions, with a lot of compliance and very less side effects, and less resistance. But as the time passed, we have seen a few patients, there are some resistance also, but I think most of them are doing very well. There are currently 4 approved integrase inhibitors, including raltegravir, elvategravir, dolutegravir, and bictegravir. They generally have a higher resistance barrier. Members of this class, including investigational drug, which is cabotegravir, are being developed for long-acting injectables, which I will discuss shortly in a little bit. So the guidelines, why to switch treatment from another. So I think there are a few things that we have to keep in mind, I think elaborated earlier on, but still we need to keep in mind the cardiovascular conditions, hyperlipidemia, renal status of the patient, liver disease, osteopenia, osteoporosis, psychiatric illness, neurological disease, drug abuse. The other thing that we have to keep in mind is pregnancy, or patient is trying to conceive, and also co-infections with HIV, including hepatitis B and C. Also, we need to keep in mind specific considerations, regimen, barrier to resistance, potential adverse effects, and drug toxicities, or to develop a comorbid condition if the patient already has existing comorbidities, known potential drug-drug interactions, convenience, pill burden is very important. So we'll discuss a case here, which is a real-time case. This is a 47-year-old male with known history of HIV infection diagnosed long time ago, around 11, 12 years ago. High risk. He has a high risk heterosexual activity. At the NIDR, his CD4 count was 131 and viral load was very high. He's been started, I think 10 years earlier on, we were starting efavirenz, Truvada was the favorite. His, I think viral load and CD4 increased, so he was very well stated. Then we got this integrase inhibitor. So we started an elbaptegravir, cobicistat, emtricitabine, tenofovir. Later was switched to another regimen, and then the integrase in a regimen. So I want to show you his cholesterol pattern that he had. If you can see, his cholesterol pattern, LDL, was initially from the beginning was very high, 5.72, the normal being less than 2. It has been high, including the triglycerides and everything. So just going back to the slide. So he had high cholesterol, LDL, triglycerides. He was started on high-dose statin and metformin, oral and hypoglycemic agents. His hemoglobin A1C remained around 8.3, and then his cholesterol and hemoglobin A1C continued to be high. So he was changed from 3-drug regimen to 2-drug regimen as dolutegravir, lamivudine plus statins. His cholesterol, you can see here, it got better a little bit, but during follow-up, we saw his cholesterol coming almost to normal, not very normal, but almost coming to the normal, and his hemoglobin A1C got a little bit better also. So also, if you see in TANGO trial, which has been run through for 3 years, you can see a better decline in LDL, triglycerides, total cholesterol, increasing in HDL, and total cholesterol and HDL ratio. Dolutegravir 3TC versus TAF-based regimen. So you can see a lot of improvement here. This is dolutegravir 3TC versus TAF-based regimen. So there's a improvement in all parameters. Again, if you go to the virological control, it is almost the same or a little bit, better in dolutegravir lamivudine arm versus TAF-based regimen. Like 5% virological failure in dolutegravir lamivudine versus 7% failure in TAF-based regimen. So I think that also gives us a lot of confidence using 2-drug regimen rather than 3-drug regimen. So ART injectables is the future. So we are just looking forward for the injectables. Every time patients come, because the patients have a habit of doing Google search all the time. So they are asking us when the injectables are going to come and when we'll be able to take once a month or every 2 months or every 6 months. So we try to explain them that it's under investigation and we'll try to get it as soon as possible. So when there was a questionnaire prepared, when they were asked how prepared they are, so I think initially the acceptance rate was low, and then in investigational models, and then I think it increased as the patient found out that it is easier way to get antiretrovirals. So cabotegravir is an investigational drug, not anymore. It has already been FDA approved. That belongs to second generation of integrase inhibitor. It is produced as an oral form as well as an injectable form, subcutaneous or intramuscular. The half-life of the drug is 20 to 40 days as an injectable formulation, which makes every month or every 2 months use. And along with this cabotegravir, we usually give relpavirine. Relpavirine is second generation NNRTI, which is an approved form. And this is combined with cabotegravir. And now there is a criteria here that we have to understand. And this is in combination, the antiretroviral drugs in naive HIV infected individuals with a viral load of 100,000 or below. So you cannot give the patients who have more than 100,000 or the initial patients that we see a very huge viral load to those patients. This is a long-acting injectable with half-life of 30 to 90 days. This formulation allows administration intramuscular injections once every 4 to 8 weeks. So it's the same as we discussed with cabotegravir. So FDA has approved cabotegravir relpavirine. And how did they approve it? So the FDA approved injectable form as a complete regimen for treatment of HIV in adults. Indication current antiretroviral regimen who are virologically suppressed or on a stable antiretroviral regimen with no history of treatment failure and no known or suspected resistance either to cabotegravir or relpavirine. So it's important to note that not all patients qualify injectables. We need to be very, very careful and cautious in selecting the patients with injectables. For this cabotegravir, relpavirine should not be any resistance in previous resistance. The viral load should be less than 100,000 and there should be no resistance previous as mentioned. We have another injectable in the pipeline, which is Lenacapavir. It's a novel first in class. It's a multi-stage selective inhibitor of HIV capsid protein. So it's an agent that is still in phase 2, phase 3 trials. In clinical studies, Lenacapavir has demonstrated successful antiviral activity and adequate pharmacological exposure up to 6 months after a single subcutaneous injection. Now the FDA approval, what approval they are going to give in this kind of injectables is that the patients who have multi-drug resistant virus and they have failed all the regimens. So this is not for the HIV naive patients, it is for the patients who have failed the regimens and heavily treated patients with heavily antiretroviral. So this would be individualized for those patients, and I believe that this indication is going to come forward for Lenacapavir with another class of drug. So these are the new drugs that's in the pipeline. This is also already approved by FDA, cabotegravir, dapivirine, islatravir. This would be with Lenacapavir. Then we have Lenacapavir, and there is another monoclonal antibody which is in the pipeline. So there are a lot of drugs in the pipeline. We have to just wait and watch. So, as I said, in the pipeline, we have apricapavine, which is NRTI. So this is important actually. This is an important medication because it can act even if there is a 3TC mutation, 184V mutation. It can be used in that 184M mutation. It can be used. It's another class of, it's NRTI, but it is slightly better than a 3TC. Albuteride is a fusion inhibitor. I think probably we did not use in the past that we had injectable, this class fusion inhibitor. And there are other new agents which binds to LAD-GFP binding on the integrase gene, and it would be active against a range of integrase resistant mutations. So these are important medications in the pipeline. So in conclusion, current oral antiretroviral drugs have been successful at reducing HIV morbidity and mortality, and have continued to provide us prevention with viral transmission from couples or homosexual or heterosexual transmission, and we need to make sure the viral load is undetectable. I think that the core message should be compliance, compliance, and compliance. They need to be complied to the medications. If they don't comply to the medication, the risk of increasing the viral load or the risk of getting resistance is very high. So adherence is crucial to sustaining progress to long-term development of long-acting injectable formulations and the potentially simplify antiviral regimen. So we can simplify, as we mentioned, to two-drug regimen. And we can see once the viral load is less than 100,000 and there is hepatitis B antigen is negative, from cost point of view and from side effects point of view. And promote adherence, allowing up to bi-monthly administration also, that injectables are available in Western countries and in US. And there will be more injectables coming very soon. And there are many long-acting injectable antiretroviral formulations at various stages of preclinical and clinical era. So with this, I conclude my presentation, and thank you for listening, and I'll take any questions.